Role of ultrasonogram in chest disease Part -5. Presented by Dr. Jalal Mohsin Uddin, Assistant Professor, NIDCH, Mohakhali, Dhaka. ILD, ARDS and cardiogenic pulmonary edema. Introduction, ILD. Considering its non-radiation, portable, and non-invasive advantages, lung ultrasound should be recommended as a valuable screening tool in patients with suspected ILD. Basic imaging patterns in ILD. Current data have shown that lung ultrasound LUS is an emerging tool in the diagnosis of interstitial lung disease ILD by evaluating numbers of B lines, pleural irregularities, decreased lung sliding, subpleural changes, nodules or consolidations. Features of interstitial lung disease in ultrasonogram. Lung ultrasound presented as numerous B lines as obtained using a low-frequency probe curvilinear probe in interstitial lung disease. Lung ultrasound can present ILD as a thickened and irregularly fragmented pleural line as obtained using a high-frequency probe linear probe. Features of interstitial lung disease in ultrasonogram. Multiple B lines. Occasional B lines up to 2 can be seen in normal lungs, commonly at the bases. They are considered significant if 3 or more B lines are seen in a single image between 2 ribs. Sonographically, interstitial syndrome appears as multiple B lines. Multiple B lines continue. A normally aerated lung with A lines artifact as reflection of pleural line. B reflections of the ultrasound beam by the thickened interlobular septa proved comet tail artifact B lines in patients with IPF. Special features of B lines: aurora sign and pleural changes. Pleural changes in ILD may include pleural roughness, pleural line discontinuity, surface irregularities, pleural thickening, subpleural nodules, aurora signs, and small amount of pleural effusion. A large number of ring-down artifact, that is aurora sign, can be observed on the dorsal side of the right hepatic lobe on ultrasound. Here chest CT or plain radiography revealed diffuse interstitial changes in the right lower lung field. Multiple B lines indicate severity in ILD. ILD can be identified using a semi-quantitative score of B lines 5. The semi-quantitative score was 0 equals normal 5 B lines, 1 equals mild from 6 to 15 B lines, 2 equals moderate from 16 to 30 B lines, and 3 equals severe 30 B lines. Features of interstitial lung disease in ultrasonogram. Examples: upper right and left, large cysts, honeycombing and severe fibrotic changes, red circle with corresponding LUS pattern in picture 2. Bottom right and left, ground glass opacities and moderate fibrotic alterations, red circle with corresponding LUS pattern in picture 4. Features of interstitial lung disease in ultrasonogram. Multiple A lines. The term multiple A lines, due to the increase in the amount of subpleural air, these occur in the case of emphysema 2 changes or honeycombing and may be a prognostic factor of severity in patients with IPF. Patients with honeycombing were more likely to have a fragmented pleural line. Features of interstitial lung disease in ultrasonogram. Pleural changes. Thoracic ultrasound TUS images of the hyperechoic pleural line in a patient with an HRCT pattern of usual interstitial pneumonia UIP. The hyperechoic pleural line white arrow appears thickened 5.1 mm when measured with a middle low frequency convex probe 3.5 to 5 MHz. Normal thickness of pleura including the pleural space is 0.2 to 0.44 mm. B. The thickened 2.4 mm, irregular, fragmented and blurred appearance. Yellow arrows becomes more evident when using a high-frequency linear probe 8 to 12.5 MHz. Evaluation of ARDS by USG of chest. Lung ultrasound can provide an early diagnostic tool to detect ARDS by showing B-lines with inhomogeneous and gravity-independent distribution, spared areas, pleural line thickening, and subpleural consolidations. Evaluation of ARDS by USG of chest continue. Heterogeneity is the hallmark of imaging abnormalities in ARDS. Therefore, these abnormalities should be screened bilaterally in 12 areas as previously described. Evaluation of ARDS by USG of chest continue. Identified by the presence of bilateral, diffuse lung rockets, that is 3 or more B-lines per intercostal sonographic field. Heterogeneous distribution. Pleural interface abnormalities and absence of significant pleural effusions. Evaluation of ARDS by USG of chest continue. Many and thick B-lines generate an image of white lung, which is regarded as a typical pattern of wet lung. Spared regions are areas of sonographic healthy lung A-lines and black lung between 2 areas of sonographic diseased lung B-lines or white lung. Evaluation of ARDS by USG of chest continue. A visual score based on number of B-lines permits a semi-quantitative evaluation of the amount of extravascular lung water and lung density. These B1 lines reflect the thickening of the interlobular septa. In patients with significant aeration loss, these B lines become coalescent and are therefore labeled as B2 lines. Spared regions. Evaluation of ARDS by USG of chest continue. Pleural line abnormalities, consolidation, spared lung areas, exudative epleural effusion, and lung pulse sign were significantly more common in patients with non-cardiogenic pulmonary edema. Lung consolidations with significant aeration loss appear as poorly defined hypojoy areas, in which hyperechoic lines or pinpoint images related to air bronchogram can be identified. Evaluation of ARDS by USG of chest continue. Pleural line abnormalities can be visualized by ultrasound as thickening, irregular or with presence of small subpleural consolidations, leading also to a reduction of lung sliding. Evaluation of ARDS by USG of chest continue. Consolidations are visualized by ultrasound as hyperechoic punctiform or hepatization areas with the presence of static or dynamic air bronchograms. Sometimes, pleural effusion may be also present in ARDS and can be easily diagnosed and quantified by ultrasound, showing an anechoic homogeneous area limited by diaphragm and pleura. Difference between cardiogenic pulmonary edema and ARDS in ultrasonogram of chest. Acute cardiogenic edema. Ground glass rockets, white lung, thin even appearance of pleural line, normal lung sliding. Homogeneous appearance of lung tissue, transsudate appearance of pleural effusion. ARDS. Ground glass rockets, white lung, thickened, uneven appearance of pleural line, inhomogeneous appearance of lung tissue, spared areas. Lung tissue consolidation. Air bronchograms. Lung pulse. Exudative appearance of pleural effusion. In ARDS patients, lung ultrasound patterns consist of bilateral B lines and consolidations and can be differentiated from cardiogenic hydrostatic pulmonary edema by looking for pleural abnormalities or spared regions of lung. Characteristics of cardiogenic pulmonary edema. The picture showing septal pattern of early cardiogenic pulmonary edema (CPE). The pleural line is regular. B lines are separated, laser-like artifacts, spreading from the pleural line to the bottom of the screen with convex probe 6 MHz. Characteristics of cardiogenic pulmonary edema continue. Characteristic ultrasound picture in cardiogenic pulmonary edema. Hydrostatic edema is the hyperdense, non-consolidated superficial lung which is due to the presence of multiple focal, patched or diffuse vertical artifacts, B lines fanning out from the lung wall interface. White lung, characterized by a granular and mostly white texture which starts at the pleural line and ends at the bottom of the screen. Approach to a patient with interstitial syndrome in ultrasonogram of chest. No hydrostatic edema. No. Cis. Yes. No AEDS. Pneumogenic problem. No hydrostatic edema. No ARDS. Focal. Consider. Hydrostatic edema. ARDS. Diffuse interstitial lung disease DILD. Septal pattern. Hydrostatic edema. Patched or inhomogeneous. Gravitational consolidation. Downward arrow. If pleural irregularities without large consolidations. Intermediate and late ARDS. Consider DILD. Cardiac ultrasound. Downward arrow. Diffuse. Inhomogeneous. Consider early ARDS, late hydrostatic edema. DILD if pleural irregularities. Conclusion. Acute cardiogenic pulmonary edema. Chronic heart failure. Clinical setting. Acute. B lines number. Plus. Chronic. Plus. Acute. Plus. Ali ARDS. Pulmonary fibrosis. Chronic. Plus. B lines. Distribution. Multiple, diffuse, bilateral white lung. Multiple, diffuse, bilateral, following decubitant regions black and white lung. Other LUS signs. Pleural effusion. Pleural effusion. Echocardiogram. Abnormal. Abnormal. Non-homogeneous distribution, presence of spared areas. Pleural effusion, pleural alterations, parenchymal. Consolidations of various size. Likely normal. ALI equals acute lung injury, ARDS equals acute respiratory distress syndrome, LUS equals lung ultrasound. More frequently posterior at lung basis. Pleural thickening. Likely normal. Thank you all. End of part -5. Role of ultrasonogram in chest disease part -5. Learning pulmonology.